Hey everyone, welcome back. I am absolutely thrilled you're here for another deep dive explainer. Today, we're unpacking a fascinating and frankly absolutely critical topic in pediatric cardiology, Tetralogy of Fallot. We're going to get right into the weeds on the precise medical management of the most common cyanotic congenital heart defect. We'll trace exactly how medical professionals take a tiny infant from a state of critical oxygen deprivation all the way to a permanent surgical cure. Let's get started.
So, here's our roadmap for today. First, we'll lay the foundation. 2, we'll look at managing acute cyanotic spells. 3, escalating to ICU interventions. 4, at-home care strategies. And finally, number 5, total surgical repair. All right, section 1, the foundation.
Okay, so to understand the management, we really need to know what we're dealing with anatomically. Tetralogy of Fallot, or TOF, belongs to the conotruncal family of heart lesions. And the absolute root physical cause of this whole condition really boils down to one single primary defect during fetal development, an anterior deviation of the infundibular septum. Basically, this one little piece of tissue develops slightly out of place, and it sets off a domino effect. This results in a combination of 4 specific, distinct structural defects in the baby's heart. It's actually fascinating to see how that single primary septal deviation forces these 4 distinct mechanical failures. If you look at this, you can see how the anatomy just gets totally crowded and misaligned. Blood that's supposed to travel smoothly to the lungs to pick up oxygen gets blocked, and the deoxygenated blood is instead shunted directly out to the body. This right here is exactly what causes that hallmark blue tint, or cyanosis, in these babies. Breaking down those 4 structural components, here's what we've got. 1, pulmonary stenosis, which is basically a narrowing of the exit from the right ventricle. 2, right ventricular hypertrophy. That's a thickening of the heart muscle just because it's having to pump so incredibly hard against that narrowing. 3, an overriding aorta, meaning the main artery is sitting right over a hole in the heart. And 4, a ventricular septal defect, or VSD, which is that actual hole between the lower chambers. Now, the absolute crucial point to remember here is that the severity of the baby's cyanosis is directly tied to the severity of that very first defect, the pulmonary stenosis. Simply put, the tighter that pathway to the lungs is, the bluer the baby. You know, it's kind of wild to think about how long this anatomical puzzle completely stumped the medical community. The condition was actually first described way back in 1671 by Niels Stenson, but it wasn't until 1888 that French physician Louis Arthur Fallot published a full, comprehensive description, which, of course, gave the condition its name. For centuries, doctors literally could only watch these patients suffer. The real turning point, the moment modern medicine finally fought back, was in 1944, when surgeon Alfred Blalock and cardiologist Helen Taussig performed the very first surgical repair over at Johns Hopkins. A total game changer. Which brings us to Section 2, Managing Acute Cyanotic Spells. Okay, so infants with TOF can suddenly experience these massive drops in blood oxygen. We call them TET spells, or hypercyanotic spells. And make no mistake, these are true medical emergencies. The absolute first-line, non-pharmacological steps taken by medical staff are critical. Step 1, place the infant in a knee-chest position. Step 2, give oxygen at 3 to 5 liters per minute. And step 3, establish a calm, isolated environment. Because crying actually increases oxygen demand and makes the spell much worse. Calming the child down is literally a vital medical intervention. Now, let's look closer at that first brilliant step, the knee-chest position. By physically bringing the baby's knees up tight against their chest, you're immediately kinking the femoral arteries in their legs. Why do this? Well, it massively increases systemic vascular resistance. Basically, you're creating a higher pressure in the body than in the lungs. This physical pressure shift acts like a dam, forcing blood back through the heart and into the pulmonary artery, overriding that stenosis and buying absolutely critical time to get oxygen up to the brain.
All right, Section 3, escalating to ICU interventions.
So what happens when that spell just won't break? That's when we turn to targeted emergency pharmacology. First up, we push a bolus of IV fluids, specifically 10 milliliters per kilogram of normal saline, just to get that blood volume up. We also administer morphine subcutaneously. This doesn't just keep the kid calm, it provides some essential muscle relaxation. Next is sodium bicarbonate, given IV to correct the really dangerous metabolic acidosis that builds up when the body's tissues are starved of oxygen. And finally, a super vital drug, propranolol. When given IV, propranolol specifically relaxes that spasming and fundibular muscle in the heart, directly reducing the physical blockage to the lungs.
But if all those measures still fail to control the spell, the child is rushed to the ICU for a heavy-hitting intervention, phenylephrine. Administered first as a bolus and then as a continuous IV infusion, phenylephrine is a potent vasoconstrictor. It rapidly spikes systemic blood pressure and vascular resistance. Think of it exactly like that knee-chest position we just talked about, but chemically amplified. This immense systemic pressure effectively blocks the blood from taking the easy way out to the body, drastically reducing the right-to-left shunt and literally forcing that deoxygenated blood into the lungs to get the oxygen the child so desperately needs. Moving on to Section 4, At-Home Care Strategies. Once the acute crisis is managed and the child is stabilized in the hospital, the whole battle shifts. The new goal? Keeping the child safe and healthy at home while they grow big enough and strong enough to safely undergo surgery. This at-home phase requires a really comprehensive plan, and it relies heavily on empowering the parents. First and foremost, we have to educate parents to instantly recognize the onset of a spell and know exactly what to do, starting, of course, with that knee-chest position. On the medical side, the infant will take daily oral propranolol to help prevent the muscle spasms that trigger the spells in the first place. Nutritionally speaking, a high-calorie diet is totally non-negotiable. The infant has to gain enough weight for surgery. And lastly, oral iron supplements are given to help mature red blood cells, which maximizes the blood's capacity to carry whatever oxygen it manage to get. Finally, we reach Section 5, Total Surgical Repair. It's really incredible to realize that while all those management strategies we just covered are brilliant for stabilization, total surgical repair is the actual true cure. The most common technique here is a transatrial transpulmonary artery approach. What this means in plain English is that the surgeons are going directly inside the heart to permanently correct those very specific anatomical deviations we looked at back in Section 1. They are physically fixing the plumbing. To give you a visual on those two major curative steps, check this out. Step 1, on the left side, you'll see the surgeon placing a physical patch right over the ventricular septal defect. Closing up that hole between the chambers immediately stops the mixing of oxygen-rich and oxygen-poor blood. Then, step 2 on the right, they reconstruct the right ventricular outflow tract. Essentially, they widen that narrowed, restricted pathway to the lungs, often using another patch to relieve the pulmonary stenosis. By sealing the hole and widening the path to the lungs, the blood can finally flow exactly how it's supposed to. All of this brings us to a highly reassuring take-home message directly from our source material. The care of children with Tetralogy of Fallot and their transition to adult life has been a success of modern medicine. And it really is. Thanks to the precise management protocols and sheer surgical brilliance we've just walked through, the vast majority of these children survive early repair and go on to have essentially completely normal childhoods. It's an absolute triumph of pediatric cardiology. We have literally gone from a condition that was a mysterious, fatal anatomical flaw in the 1600s to a manageable crisis and now to a completely curable condition today. So I want to leave you with this thought. As surgical techniques and medical management protocols continue to advance at just breakneck speed, what other complex congenital defects might one day transition from being lifelong burdens to completely curable conditions? It's something to think about. Thank you so much for joining me on this explainer. Keep asking questions, and I'll catch you next time.